Thank you. Hello, and good morning, everyone. Welcome to a special session covering a statewide landscape scan of the Food as Medicine initiatives in Texas, hosted by the Health Equity Collective's Food Security Work Group. My name is Alicia Johnston, and I'm a Health Equity Collective volunteer. I serve on the steering committee as well as co-lead of the communications work group along with Wes Gibson. I'll be helping facilitate today's session alongside Felicia Coleman and Jasmine Lanier. A few housekeeping items before we begin today's presentation. The meeting is being recorded, so if you do not wish to be recorded or on camera, please go ahead off camera. Please keep yourself on mute unless speaking. We encourage everyone to use the chat to ask questions, comment, or share related resources throughout the session. We do have someone monitoring the chat, and there'll be dedicated Q&A at the end of the presentation. If you've not done so already, please just take a moment to introduce yourself in the chat so we know who's here. And then the recording will be shared after today's session. We post that onto our YouTube channel, and I'll go ahead and share that link in the chat so everyone has access to that. You can visit the YouTube channel to see past recordings as well. So for those of you who are not familiar with the Food Security Work Group, who are the hosts for today's session, the Food Security Work Group is one of 7 work groups that make up the Health Equity Collective, and its mission is to develop a shared set of evidence-based interventions to improve food security and healthy food intake in our region. You can learn more about the Health Equity Collective, our work groups, and how to get involved by visiting the Health Equity Collective's webpage, also dropping that link in the chat for everyone if you'd like to visit our refreshed webpage. And with that, I'll go ahead and introduce our speakers for today. First up, we have Naomi Tice. Naomi is a project manager for the Center for Health Equity at UT Health Houston School of Public Health. Naomi's work focuses on increasing consumption of fruits and vegetables and identifying and breaking down barriers in our food system that lead to unhealthy diets. Naomi graduated with her master's in public health from Johns Hopkins Bloomberg School of Public Health with her certificate in food systems and joined the Center for Health Equity in 2023. Wes Gibson, the communications co-lead, will also be supporting and presenting today. Wes Gibson is a senior program manager at the Center for Health Equity with extensive experience in system science, partnership engagement, and data equity. Wes specializes in key performance indicator dashboards and Power BI and interactive maps to support data-driven decision-making. In addition to managing REDCap databases across various studies, Wes translates materials into Spanish, authors articles and social media content for the Center for Health Equity, and co-leads the communication work group. Naomi, I'll go ahead and welcome you to the virtual stage. Over to you.
Awesome. Thank you so much, Alicia. Okay, I'm going to try to share my screen, y'all, so bear with me if it doesn't work the first time around. How is that looking on y'all's ends? Good? Okay, fantastic. All right, so excited to be sharing this presentation today. This is really not even the culmination, but I guess the midpoint of quite a bit of work that's been happening at the Center for Health Equity, and then also just kind of across our collaborating partners and the Health Equity Collective as well. So like Alicia mentioned, we'll be presenting on the statewide Food as Medicine landscape stand that we've been working on at the center for the last 2 years. And I'm so lucky to be co-presenting with Wes today. Before we get started, I just want to say, let's see if I can switch there we go. I just want to say some huge thank yous to Dr. Sharma and the Center for Health Equity in general. Dr. Sharma, in supporting all of this, the project was funded by the Center for Health Equity, but has really been a collaborative project across a wide swath of partnerships. We've had some amazing students that have been supporting this work and were working really hard with us throughout the data collection process and the questionnaire design process as well. And then the Coordinating Center for Clinical Trials at UT Health also was an amazing support for some of the data analysis. And then we'll look into, Texas Consortium, Food Security Work Group, and then Cassidy Penn. So much amazing support kind of across the board. All right, with that being said, let's jump in. So I know that this is probably not new for most of our audience today, but really just wanted to take a moment to talk about kind of the general state of health in Texas. So we spend nearly half of Texas' budget on healthcare, and that's about $43 billion. And yet 23% of adults in Texas have at least one major chronic disease. And then we see that Texas is slightly lower than the national average in our consumption of fruits and vegetables, which we know that increased consumption of fruits and vegetables can treat and prevent chronic diseases and diet-related diseases. So with this kind of context, we need to do something different, right? So what we are doing across the state in our healthcare sector, in our diet and behavior, it's not working. But what exactly is that solution? What do we need to be geared towards? And that is really where food as medicine comes in. So food as medicine, as defined by the American Heart Association, is the provision of healthy food to prevent, manage, or treat specific health conditions. And then with that integration within your doctor's office or a health system or a hospital system. And so I really want to just kind of pull out some pieces there. It really is the provision of healthy food. And as we kind of talk through food as medicine, I want to highlight a few differences between food as medicine and our standard food distribution. And one of them is that idea of healthy food and then that deep integration within the healthcare system, which really defines some of the differences between food as medicine and then standard food distribution. So when we look at standard food distribution, you often do see that eligibility screening, whether that's for income or food insecurity. And you also kind of have this idea of all food is good food. You're kind of trying to generally increase caloric intake. And so we're really just focusing on that food insecurity. When we transition to the idea of food as medicine, there is this idea of healthy food, the idea that what we want people to be eating is something that'll actually benefit their health overall, and that we are best suited to do that by connecting with their healthcare providers, healthcare systems, to be able to kind of track their health outcomes throughout the provision of a prescription of food as medicine. You still do see that eligibility screening, but it might look a little different. It might be more focused on a specific health condition versus just looking at food insecurity. So as we talk about food as medicine, we really are talking about simultaneously this kind of shift in state and national priorities. So we have focused so heavily on food insecurity, and we're seeing over the last year, over the last few months, really this focus towards healthy eating. And you see that both on the federal level and you're seeing on the House level, or I'm sorry, the state level. And so these two items that I kind of have highlighted here are just two examples of that. So one of them, the Office of Nutrition Research recently put out their strategic plan. And in that strategic plan, it specifically calls out food as medicine as a tool, as a resource to be able to attribute the impact of these interventions on health, improving health. And that's really kind of what we're looking towards, is how can we say definitively that increasing our fruit and vegetable consumption, improving our diet, is really improving those health outcomes that we looked at earlier. And then with the close of the legislative session, we saw the passing of House Bill 26, which does allow for nutrition education to be provided in lieu of services and reimbursed through Medicaid, as well as a very limited food as medicine intervention component, which was just medically tailored meals specifically for pregnant women. But we're still seeing that there is that trend both on the national level and on the state level towards food as medicine and towards focus on healthy food provision. So the next question is kind of, what is the current state of food as medicine in Texas? So I think this, at the Center for Health Equity, we work, with national partners, and we kind of get this question a lot, like, what is going on in Texas? Is there things going on in Texas? What does food as medicine look like in that state? And I think we also see that there's times when food as medicine Texas kind of misses the boat in drawing down some of those federal funds that could kind of support some of these initiatives. So we really had this goal of being able to answer this question: what is the state of food as medicine in Texas? And this, the Center for Health Equity is really uniquely positioned to be able to answer that because of the amazing collaborations and partnerships that we have across the state, which is really what we leaned on as we work to kind of answer this, develop out this landscape scan in general. And so really the goal here was to create statewide sightlines. By being able to better understand what's happening in the state, we can understand who's already implementing food as medicine in Texas, and then how our implementers, funders, health systems, how are we connected as we're doing this work together? And then really what are best practices that are most specific to Texas as we continue to build out this field, as we continue to collaborate, how do we need to adjust to make sure that we're best serving Texans? And then we are looking to rapidly scale these as we see consistent evidence towards food as medicine being able to successfully impact health outcomes. But there might be infrastructure that's still needed. So really, as we were kind of going into this landscape scan, that was the goal here, is to really start to create better sight lines across the state. But as we were thinking about that and discussing it with many of y'all that are in the audience today, we also wanted to better understand what work is already happening. So as we look to build collaboration in food as medicine, we didn't want to simultaneously be reinventing the wheel anywhere else. So it was really important to kind of look to our partners and understand what was already going on. And we do just want to call out the Texas Consortium here. So the Texas Consortium for Non-Medical Director, oh my gosh, non-medical, I'm just going to say NMDOH, y'all, really started a lot of this with their program index. And so the Texas Consortium went and really started looking across the state of Texas for programs that are addressing any of the NMDOH priority areas. And then within that, looking at food and looking at it more towards programs that are addressing food insecurity. And so with that, we knew that we wanted to have a little bit more specificity around food as medicine. So here are all of the programs that are addressing food insecurity in general. And then the landscape scan kind of seeks to get in a little bit more granular with some of those details. And then with the Health Equity Collective, as Leisha already alluded to, the Food Security Work Group has been doing amazing work in this area. And so this really builds on a lot of the partnerships that the Health Equity Collective has been developing out over the last 5+ years. And then also want to call out the Dell Center and the many food as medicine mini summits that they have been hosting in the Central Texas area that has really brought together implementers in that area to be able to start having some of these conversations around collaboration and kind of sharing of best practices. So we know that that is already going on in Texas, and we want to know how can we build on this. So with that being, being the general context, what is still missing? And so, like I mentioned, we really wanted to better understand not just the food programs in general, but ones that fall within that food as medicine definition of having that integration within the healthcare system and also providing healthy food. And so the landscape scan really seeks to visualize the program. So help us better understand what, how do the intervention types kind of break down across the state, what health conditions are being addressed, and then also to map where those programs are so that we can better understand where they're not. And kind of see if there's any geographical gaps that might still exist across Texas. And then always with this focus towards collaboration. And the landscape scan is 100% a collaborative effort from its inception to the design and the amazing hours that were put in by researchers and implementers to help us figure out what we should have in the questionnaire, and then just the enthusiasm and support that we've received as we're working to fill it out and follow-up questions. And we also had a Houston mini summit kind of modeled off of what Central Texas and the Dell Center was doing. And I think what really stood out to me at that mini summit was the excitement there. So we were able to hear directly from implementers. And there was lots of people who chose to linger and continue to talk once the presentations were over. And I think that really speaks to the fact that there is momentum within food as medicine, but there is also this desire to collaborate and work together. All right. So with that kind of general level setting, this is kind of what we're going to get into a little bit more today. One thing that I do want to point out, and anyone in the audience who has completed the landscape scan knows, is that there was a lot of information in it. It was quite comprehensive, and we won't be able to get into all of that today. But Wes has worked amazingly hard to build out a KPI dashboard for the landscape scan that is interactive, and there'll be QR codes at the end of the presentation for you to be able to kind of explore that a little bit more on your own. So I'm going to give just kind of a general overview of some of the things that we found, but please know that there was so much more, and that data is also available. And then food as medicine is a collaborative field. And so we're going to spend a little bit of time talking about the partnerships that are necessary to successfully implement these programs. We'll get in a little bit some of the program details, and then we'll wrap it up talking about funding and next steps. All right. So this slide right here gets me very, very excited because I think this is a culmination of quite a bit of work over the last year and a half. And before we kind of get into the breakdown of intervention type, I do just want to talk for a minute about the definition of these different interventions, because I think that is one of the challenges that we saw as we were trying to implement this landscape scan, but also that's kind of consistently showing up across the field, that there aren't clear set definitions, recognized by everyone. And so what we did as we were developing out the landscape scan is we worked to kind of review general definitions, and then really leaned pretty heavily on the American Heart Association's definitions of intervention types. And so the 3 intervention types that we started with were medically tailored groceries, produce prescription, and medically tailored meals. So medically tailored groceries are going to be groceries that are prescribed. That's going to be mainly raw fruits and vegetables. It might be whole grains, but it's prescribed by a dietitian, nutritionist for patients, and it's usually to treat a specific chronic condition or increase overall diet quality. Then we have our produce prescription program. I think this is where we saw the most confusion, disagreement, kind of conversation around intervention types, because how we have defined a produce prescription program is providing a voucher or a coupon for participants to go to either farmers markets or farm stands or grocery stores and purchase healthy foods. And then lastly, we had our medically tailored meals. Medically tailored meals is probably a food as medicine intervention type that has been around the longest. I think it has the most agreed upon definition, which is really the provision of healthy meals prepared and designed by a registered dietitian. So we started out with those 3 categories, and that's really where we sought out those that we knew were implementing, and we, were able to gather more information around organizations that were implementing those. But as we collected this information, something else that we saw was that culinary medicine programs kept coming up. And so we have 5 that are represented in these 48 programs. We do not in any way believe that that's comprehensive, but did want to include those in here because culinary medicine is such a key component to food as medicine. And that is the teaching of how to prepare healthy food to help manage a chronic condition. And so culinary medicine does not usually provide food, but instead helps people learn how best to manage their own diet. And then we also had these combined interventions. And that really is quite different than one of them on their own. And so that could be medically tailored meals combined with a produce prescription, or medically tailored meals and medically tailored groceries. And the way that's implemented is slightly different, which is why we chose to call it out as well. So with all of that kind of said, you can see that medically tailored groceries are far and away the most popular, the most common type of food as medicine intervention. And then medically tailored meals is going to be on that lower end. And I think that really does speak to just the cost of implementation of these two different types of interventions. Medically tailored meals are usually more specific to a chronic condition, and they have a higher expense attached to them. And medically tailored groceries are usually on the it's a less expensive intervention type and can be more easily adapted to a variety of chronic conditions or diet-related diseases. So we had those unique 48 programs that we identified across the state, and within that there was 24 unique health sponsors that are implementing this program, which does mean that some of our health sponsors are implementing multiple food as medicine programs. Alrighty, so the next thing that we kind of wanted to look into is what phase of implementation are these programs in? And so what we saw, one of the questions that we asked was, when did you first enroll your first participant? And I think it was really exciting to see that the first program was started in 1988, which does speak to the idea that not only is food as medicine not that new, but it also has been happening in Texas for quite a while. And that is going to be a medically tailored meals program. And then you do kind of see this gradual increase and then a jump that happens around 2019, 2022. So you see there that there is this increase in popularity of food as medicine interventions. But in Texas, we have 17 programs that are in the sustainment phase. And how we define that is these are programs that are built into the operations of their organization. These are programs that are well established and less likely to be cut or to change due to funding or other issues like that. So we also have about 15 programs that are in the implementation stage, which does align kind of with this increase in programs over the last 5 years. All right, so the next question that we looked at is what health conditions are being addressed by food as medicine programs? And it's important to note that this is a select all question, which means that a food as medicine program is able to be addressing more than one health condition. But what we did still see is that these diet-related diseases, diabetes, prediabetes, hypertension, obesity, and overweight are still kind of overwhelmingly where food as medicine interventions are focused. But you also see them being applied to different types of health conditions. And so I think when we get into the conversation around evaluation and being able to see the impact on health conditions, that is really exciting because we really can see how can we apply food as medicine programming maybe to different patient populations or to different health conditions and kind of see that general health improvement. And so then one thing I wanted to point out is that we have 30 programs that are specifically addressing diabetes or prediabetes. And of those 30 programs, 43% of those programs are in sustainment. So those programs are established and they're working well. And so I think that really does speak to food as medicine, really focusing initially on diabetes and these diet-related diseases, but with the potential to really kind of expand out to other health conditions as well. All right, and then I am going to pass this over to Wes for him to walk us through some of the amazing mapping that he has done of food as medicine programs.
All right, one moment. Let me share my screen. All right. Okay, can everyone see the map on their screens? For the Okay, great. And just so you all know, this will be available for everyone. We'll put it on our project page. We'll also, it'll be a QR code at the end of the presentation, and we'll send it as a link as well. So, as Naomi alluded to, the food, what we'll show here is, of course, where there is food as medicine programming, but this map will also give us the chance to compare where there's food as medicine programming and how that compares with the age-adjusted prevalence of diabetes, obesity, and hypertension, because these were also the top 3 conditions addressed in the landscape scan. We obtained this data from the 2024 CDC Places data. So first and foremost, just to break down, I'm not going to go through all these words, but if you can look at them later. Overwhelmingly, there are 27 programs in Harris County. And then after that, we have 8 in Fort Bend, 5 in Brazoria, 5 in Bastrop, 5 in Dallas, 5 in Hayes and Travis. And overall, this is the Central Texas area and then Dallas. So there's overall metropolitan area coverage. I won't go through all the breakdown, but then on this right-hand column, you can see, okay, well, out of the 27, what's the breakdown? How many are medically tailored groceries, etc. And again, overwhelmingly, most are medically tailored groceries. So altogether, out of Texas's 254 counties, there are 62 that have coverage of food as medicine, at least according to the responses in the landscape scan. So as you see here, there's a lot here on the east side of Texas, here in Nueces, here right here in Hidalgo, and the southern tip, El Paso, and a little bit here in the near the Panhandle area. What you can do on this map is you can click on a specific county, and then of course it'll show you the county name and then the breakdown specifically of what programming there is. So I won't go over every county, but when we send this link out, you'll be able to do a more in-depth dive, zooming in and out to see these areas that are covered in the black and X's are areas where we see food as medicine programming. The words below give you a little bit of an explanation of how to use the map. So let's start looking at some of the prevalence. So this first map here shows us the age-adjusted prevalence of diabetes, all right? And to the left, you'll see a legend. So the darker the red, the higher prevalence, the top being roughly 24%. And so you'll see this not only with diabetes, but the other health conditions is that it's very high along the border. Not to say that it isn't, that one case isn't insignificant, but this at least gives us an idea of, okay, where there is food as medicine programming, and again, diabetes is the top condition addressed. How does this compare with what we're with the burden that Texans are experiencing? Again, you can click on a county, and you can use this hover feature to see what the specific prevalence is if you want to go beyond the legend to see a specific percentage. All right, and then the second health condition addressed is obesity. And again, here the rates go pretty high up to nearly 50%. So that is saying that more than roughly half the population is overweight. And again, it shows us how where programs are and where there are gaps. And then lastly, we include hypertension. All right, and again, you see a similar trend, but there are some high areas here on the East Coast compared to the other conditions addressed. And yes, some of these dark areas, again, we're seeing that there's the need to expand this. I know we have a lot of other areas to cover, but this will be available, and this map shows us where the programming is and how it compares to conditions addressed. So I'll pass it back over to you, Naomi.
Awesome. Thank you, Wes. Alrighty. So the next piece I really want to go into is program partnerships. So one of the things I think that we have spoken about previously, and that just comes up again and again when we're working within the field of food as medicine, is the importance of partnerships. And the Center for Health Equity, as we have designed programs, as we have evaluated them and worked with other organizations doing the same, have really found that there are 4 key stakeholders that need to be engaged in a food as medicine program to really optimize success. And that's going to be the healthcare system, which we've spoken about a little bit. Food as medicine, kind of by definition, needs to be integrated within some form of healthcare system. But what we also want to kind of focus on is this need for community-based organizations to be at the table and a part of both the development and the implementation of food as medicine programs. And I think what was really exciting as we looked through the results is that 81% of programs did list at least one community-based organization that they were actively working with. And I think this is really crucial because we know that community-based organizations really have that direct line to the communities that these programs are seeking to serve and can really help with uptake and implementation and sustainment of these programs going forward. And then program vendors, so we'll often also call this produce distributors, but because we have vouchers that are included, program vendor is a little bit more accurate. It says 90%, but that's because we included in that the 5 culinary medicine programs. And culinary medicine programs, by definition, don't necessarily have a produce distributor. So it really is 100% of programs have some way of either, distributing produce or their vouchers. And then lastly, this design and evaluation piece, and we'll talk a little bit more about it in another slide. But what we're seeing is it's a relatively low level of evaluation that's happening across programs, and we can talk a little bit more about, what that kind of means for the field. So breaking the program vendors down, looking a little bit closer into vendor type. So one of the things that we did, so the initial 3 fields were for-profit, nonprofit, and other. So food bank was not one of the initial fields when we were talking about vendor type. But what we saw consistently is that in those open responses that were so fun for us to analyze, the food banks kept coming up again and again. So we were actually able to pull them out as a unique vendor type. We saw that 47% of programs are working with food banks for that produce distribution or as their general program vendor. And then one of the other things I wanted to highlight from this is these nonprofits. So for-profits. So our for-profits were about a quarter of our overall program vendors, but what we saw is that they were 100% of the medically tailored meals vendors. So there is within the field of medically tailored meals, what we were looking at is that 100% of the people who are the companies that are offering this or collaborating with programs are for-profit. And I think this really gives us a space to talk about, what other people do we want to bring into that field, or how does this kind of impact the field overall? So kind of next going into that program evaluation component. So we just asked at the beginning of each program, is this program being evaluated? And what we saw is that 46% of programs are being evaluated, but 29% of programs are collecting some sort of health data for evaluation. And so I think what this allows us to see is that there is space already built into these programs for increased levels of evaluation, but it isn't quite happening yet. And I think as the field of medicine looks to grow and spread across the state of Texas, as we look for more innovative and sustainable funding mechanisms, it'll be really important that we are able to provide that evaluation and that health impact knowledge around these programs. And then what we also saw when we were looking at methods of collecting health data is that over 50% of these programs are already using electronic health records to collect some sort of patient data, which once again kind of speaks to that integration within the healthcare system and really does provide that opportunity to kind of dig in a little bit more to better understand health outcomes. And then about a quarter of programs were also directly collecting biometric data as well. So there is a lot of health data that is being collected, and there is that potential to evaluate it so that we can better understand what is the impact of food as medicine, especially on some of these new chronic conditions that we're looking to address. All right, one of the constant questions that comes up as we talk about kind of designing new programs or implementing new programs is this question of the individual versus the household. So when we think of food as medicine as a prescription, we prescribe to an individual patient, right? And so there is this idea that food as medicine as a prescription, as a part of the healthcare system, should be for an individual patient. At the same time, we also understand that both food insecurity and food generally are more of a household construct, right? We encourage people to eat in community, to share meals together. So there is a little bit of this push and pull back and forth about what level these programs should be implemented on. And I think what's interesting is when we look across these diet-related diseases that I pulled out specifically here, is while that is a lot of conversation, what we're seeing is there's already almost a 50-50 split between household and individual. And I think that really does speak to the fact that if we are asking and we are looking for behavior change and diet change, addressing the family as a whole might be the most effective way to do that. And then I also wanted to pull out pregnancy here, because that is actually where we see kind of the biggest discrepancy between individual versus household, which I think makes sense, right? Because pregnant women, we know that they have specific nutrition requirements, and we really want to target them. But there is still that conversation to be had of, is a pregnant woman or a postpartum woman going to be eating the whole prescription on their own, if they also are a part of, a family unit. And so what does that kind of look like as we're designing out those programs? And then you'll see that there's, a 2% that's not accounted for. And that's because we do still have some programs that were included that are still in the exploration or the preparation phase. And so they're still kind of deciding if they want to be at the household or the individual level. So with House Bill 26 passing and this increased focus on general nutrition education and culinary medicine, it became really important for us to understand what was already happening in this space within food as medicine programs. And I think what was really great to see is that 73% of programs are already offering some form of nutrition education. So nutrition education really is generally viewed as a key component to food as medicine programming. Now, what that nutrition education looks like is vastly different across programs. So we can have one-on-one instruction, which might be like classes, teaching people how to cook, doing some of this nutrition counseling, all the way to text messages that might just have, tips on how to manage your diabetes. So what is being provided is very different across programs, but I think it's key to see that the majority of programs do understand the role that nutrition education does play in this space. And then we also wanted to understand is who is, kind of designing and sharing this nutrition education with participants. And absolutely makes sense. And it's great to see that 38% of programs are leaning on registered dietitian nutritionists to design those programs, to design the curriculum, but then also to speak with the participants. I think it's also important to note that 27% of programs are working with community health workers. And as we see that field growing and that workforce really growing across Texas and more reliance of healthcare systems on community health workers, how do we want to train our community health workers to really be well situated to provide that quality nutrition education that needs to come with food as medicine programming? All right, and then almost last, certainly not least, is food as medicine funding. And I think this is such a massive conversation that's happening as this field does look to rapidly expand. And as we are thinking about how do we sustain food as medicine in the state. And I think one of the things that was alarming for us, we asked, is your program likely to continue after this funding cycle? And 60% of programs said that they are not likely to continue after the current funding period. And I think as we are thinking about the ability of food as medicine to really support the health of Texans, this is something we really need to be talking about. We understand, that government funding in this area is decreasing, which is also directly impacting operating budgets. While medically tailored meals for pregnant women was passed as a pilot program in the last legislative session, that was very limited, which means we're not going to see a huge increase in payer reimbursement, at least in the next 2 years. So where are funds going to come from to continue to sustain this field? And I think thinking about innovative funding mechanisms, but also, kind of building on the funding mechanisms that may already be working is a big conversation that we need to be having. All right, so lastly, here are the key takeaways like I mentioned, there's so much here. And really, it was so exciting to kind of see the energy that was around this work and the willingness of people to share about their programs, to come to the mini summit, speak in person, to collaborate. And so I think one of the things that is very, very clear is that food as medicine both meets the moment of, this focus on healthy eating, um, and is also really being implemented quite robustly across the state. I think we're also seeing that there is some need for increased programming. So as Wes kind of highlighted, there are geographical gaps. Programs are really centered around our urban centers. I will say that there is some respondent bias there. Obviously, the Center for Health Equity is situated in Houston. And so, that probably contributes to why we have such a high rate of response in the Harris County area. But we did work quite hard to reach out to as many implementers and kind of use that snowball sampling to be able to identify programs. So while we can't say that we've identified all of them, I think it is fair to say that there are still some significant geographical gaps in programming. And then just wanted to reiterate again and again the fact that partnership is key, and bringing in, our community-based organizations with our healthcare systems, and then also generally working to make sure that we are evaluating these programs and we do understand the impact as we look to build this field. And then the landscape scan is ongoing. So this is just phase 2 of the data analysis. We have learned so much, not only from the data itself, but also how to create and distribute a landscape scan. We will definitely have less open responses in round 2, but we do, if you haven't had a chance to fill it out, if you are implementing a food as medicine program, please share that information with us. And like I mentioned, there are a couple places for you to more deeply engage with this work. We do have the landscape scan dashboard. You can scan the QR code and it'll take you there, where you can kind of dig a little bit more into the program specifics, filter by different health conditions. And that map that Wes was sharing is also available for you to continue to kind of look into and dig around in. There is so much that is happening in this field, and the center does plan to continue to collect this information and also share out program information going forward. Alrighty, so massive thank you to y'all for sitting through this presentation, and then for everyone who has responded, provided feedback, and really helped us work through this entire process. And we are so excited to continue building on this, to continue improving the scan itself and sharing out what is happening within the field across Texas. And so as we open it up to questions, I did just want to kind of provide one to the audience, which is, what did we not talk about? What would you still like to know about food as medicine in Texas, about collaborations across implementers? We're continuing this work and want to hear from you to make sure that it is as applicable and usable as possible. So thank you. I'm going to stop sharing my screen now.
And I will open it up for you, Naomi. Felicia and I were looking at questions. And thank you so much for the presentation. I'm Jasmine Lehner. I co-lead our learning series work group along with Felicia here. And we do have one question for you, Naomi. Was there any research done on the level of funding needed to sustain these programs included in the landscape scan?
Ooh, I think that is a fabulous question. I don't know if the person who asked it wants to come off mute and kind of provide what they're thinking with that. I think we have a general idea, like as we're building out these programs, what is necessary to be able to provide a comprehensive and holistic intervention, and then also the cost of that integration within the healthcare system, and then evaluating it as well. but I didn't know if that kind of addresses there, if there's a little bit deeper information that's kind of wanted with that. Also, I'm just gonna open it up to Wes and Dr. Sharma. Please feel free to jump in and answer any of these questions as they come up as well.
Hi there. Yeah, that question was from me. My name is Amanda Rolick. I'm a food policy advisor at the City of Austin. And I was just curious, I guess in general, like, what does the funding landscape look like for these projects across Texas? And if you'd included sort of like level of investment that has been put into these programs, just information around that so we can sort of better understand what level of funding is needed to sustain or even launch certain projects across the state.
Yeah, Amanda, this is Shrila. I think that's a great question. And right now, predominantly, as Naomi shared, these programs are being funded through external funding, philanthropy, grant funding. So I think the overarching intent nationally, or the momentum, has largely been with around food as medicine specifically, has largely been with the intent of having healthcare dollars pay for healthy food provision so payer engagement essentially. So I think in the work we're doing with the Food Security Work Group, Health Equity Collective, a lot of that conversation continues to happen, that is the intent and the hope as organizations are initiating these, health systems are initiating these because they're screening for food security. They want to meet the needs of the patients. Sustaining these is going to require a model that goes beyond grant funding. It's going to require operational dollars. It's likely going to require payer engagement. And so I think that's sort of the direction that everybody wants to go in. We just have to figure out how to make it happen. There are some, the good news is that at least we know there's a few payers, managed care organizations that are moving in that direction. So I think that's really positive to see.
Thank you. Another question that we have is, how does local community health workers living in or working in food deserts connect with Food as Medicine future programs to do the grassroots work?
Yeah, I think that's a phenomenal question, especially as we are seeing the increased engagement of community health workers in food as medicine programs. I think it really does just depend on the region and the health system that's implementing the program. But I think we are kind of seeing this importance of the community health workers' ability to build that relationship with the participants, to really have them increase their engagement with the program, continue to either pick up the prescription or utilize the prescription. And so there is this space for increased community health worker engagement. And I think I would just encourage community health workers who are interested, as well as organizations that are starting to build out these programs, to really think about how they can use community health workers in this space to engage with populations and reach out to the community health workers who have walked through these trainings and have this lived experience, and also this background that's so vital for being able to successfully implement these programs.
Thank you, Naomi. Another question we have, do you know what the level of interest is among Food as Medicine partners to work with farmers to offer locally grown food?
Yes, so that's actually one of the questions that we asked that wasn't included in the presentation today, which is, where is the food coming from? Is it like a national distributor? Is it a local distributor? And so we have some of that information. And then we also saw, when we were looking through who are the actual community-based organizations that are being included and listed as partners, we did see some of them were farms. And so I think there is that interest and that desire to include local produce into these programs. I think there is also just that ongoing conversation that's needed around how do we scale as we bring in local farmers, and how do we kind of ensure that we have the production that we need and the produce that we need. But you definitely see that farmers are being included in these programs. I do think that there's more space for that for sure.
Thank you. And I have a question for you myself. How do you see technology playing a role in assisting with scalability in food as medicine programs?
That is such a fun question. I also know this is something the Houston Food Bank has doing some really exciting things with doing home delivery with automated cars, which I think is great. We also have one of the programs here at the Center for Health Equity is implementing a AI chatbot to help provide some of that nutrition education. So I think kind of across the span of the program and of the intervention, there's several different ways that we can increase our technology or use technology to be kind of more efficient in providing that like personalized nutrition education component of it, and then also making sure that we're incorporating kind of that like culturally appropriate food. So there's so much space for this, and I think as we kind of see that area growing more generally, it'll be interesting to see how it's applied within the food as medicine space.
Thank you. Okay, coming with more questions. In communities with a lack of close proximities to clinics or healthcare settings, are other considerations for the definition needs to change in some communities for these programs?
Yeah, I think that's such a fabulous question. And I think it's something that we're just seeing as we look to see where these programs are, is that there is this focus on communities that have more ready access to healthcare already. So as we look to expand to more rural areas, how does it need to adapt? And I think that that's something that like is a greater conversation that needs to be kind of happening across the field. And as we look to the next stage of this, I think that, and I see Melanie, you're the one who asked, so like, as how do we want to incorporate food banks and Feeding Texas and kind of in some of those conversations?
Thank you. Another question. I am in San Antonio, Bexar County. Are there any food as medicine programs in Bexar County?
I am going to designate that question to Wes.
Let me double check.
And while Wes is double checking, I'll just say that that map clearly shows, I mean, if there's gaps in rural, but there's, I think one of the, this is an iterative process. We're all going to learn and evolve from this, but I do think that there's also an opportunity to triangulate that with health, the burden of health, these health conditions that we have in different communities. So I think that's another consideration as well, specific to food as medicine.
And no, we didn't have any reported in Bear from the responses.
And I know we kind of mentioned this previously, but I do think it's important to note that like there is more work that needs to be done to include more programs into the landscape scan. So if that sounds inaccurate to you, please reach out. The QR code that we shared at the end of the slide, goes directly to where you can complete the landscape scan, but we want to make sure that all programs are being represented. So there might be some in San Antonio, and for whatever reason, they just have not been included yet.
I don't believe there's any more questions. I think just a comment for the future, would love to see some individual stories or personas of people that benefited from food as medicine programs to better understand how they were connected to the program, their experience, and then what was the behavioral change and health outcomes.
Yeah, absolutely. I think as we look into, bringing it policy changes and how do we kind of advocate for this, those individual stories and that qualitative data are so key. And so definitely want to make sure that we're collecting that as we also collect these other health outcomes and kind of these quantitative pieces.
Okay, one more question, I believe from Tara. How do we add this to our grocery store? Is anyone familiar with this process?
Yeah, Tara, let's chat. Like absolutely. And I think we can definitely look and see who's our produce prescription programs that are already happening, that are already using vouchers. But I think that is the exact kind of question we want to be able to use the brain trust on this call today to answer. Alrighty, y'all. Thank you so much for these amazing questions and for listening to me talk for such a long time. And really, this is all an effort that has been only possible through all of the work of everyone who's on this call. So thank y'all guys so much for your continued engagement in this work. Lucia, did we have a survey that we wanted to share out?
Yes,
Or will
there
we-
will be a survey that's placed in the chat, or actually will go out after the meeting, so it'll be a follow-up email. So that's actually helpful, be helpful for Naomi, as well as the food access, the food security learning group subgroup, which is the host for the for this session. Jasmine and I are the co-leads for that subgroup. And so if you would just take, it's a quick survey, if you take a couple minutes to complete, we'd really appreciate any feedback you could give us. With that being said, we can kind of go ahead and conclude the session for today. I want to thank you guys for participating and coming on board and just kind of learning about this very important work that's happening, especially after the legislative session. Do you want to extend an invitation to each of you to join the subgroup, food access subgroup, or the food security learning session subgroup? We are open to having you guys weigh in on some of the topics and things that we are planning for future sessions. And so we, ask for you guys to join us in that endeavor. But again, thank you guys for attending, and we wish you a wonderful Friday.